In this video, we're going to talk about kind of a mixed bag of peripheral nerve injuries. There's going to be some common themes. Infection is going to cause a few of these. Certainly the immune system is going to play a role. We're going to see a couple different cases of autoimmune targeting. And then there's some heritability, at least in some cases of these diseases. In the end, with Charcot-Marie-Tooth, that's going to be purely heritable, and then there are some heritable forms of myasthenia gravis, for example. So we're going to step through these peripheral nerve disorders. Some you might think could be included in the last lecture, such as trigeminal neuralgia. In some cases, it might be considered similar to an entrapment disorder, but it's not really, when it passes through a tight space, getting compressed. This is more going to be caused by sagging blood vessels or some sort of tumor growth. So there's a lot of similarity between the disorders in this lecture and even from the last one as well. Not just that they target peripheral nerves, but even some of the mechanisms involved. So whenever we have infection, we can target the myelin sheath, which we'll see later. We can target neurons themselves. This infection can lead to inflammation that then leads to compression and demyelination. If it continues, then we have axon degeneration. So the first disorder we're hitting here is trigeminal neuralgia. This is kind of similar to Bell's palsy in that we have loss of function of a cranial nerve that's affecting the face. Now the facial nerve is a major motor nerve for the face, but the trigeminal is the major sensory nerve for the face. It does have some motor function, but for the most part, what the trigeminal nerve is going to do is give us our non-painful and painful stimulation for most of the head, all of the face and most of the head. Trigeminal neuralgia is a disorder characterized by sharp pain that's caused by non-painful stimuli. The prevalence here is going to be about 5 per 100,000, and you can see here the age of diagnosis. We're going to tend to see this in the elderly, and that's because a major contributing factor here is going to be kind of the wear and tear on blood vessels that causes them to lose their integrity and start to sag. And the sagging of blood vessels can then put pressure on nerves and cause demyelination, and that is the key issue here. We're going to see this more commonly in females than males, and the risk factors here are going to be anything that leads to a reduction in blood vessel integrity. So age is a big one, but also, of course, hypertension and atherosclerosis. So those are going to weaken the blood vessels and then cause them to kind of distend and sag. And so you can see here that the incidence, if you look here, going from left to right on the x-axis, this is just follow-up over about 3 years. Red line is showing us the group that had hypertension, black without hypertension, and you can see that there's an increased incidence of trigeminal neuralgia with hypertension. So we're going to see a vascular cause here in many but not all cases. The clinical presentation of trigeminal neuralgia is going to be face pain. And face pain that's just caused by non-painful touch, such as when they're brushing their teeth or shaving or just eating and chewing. We're going to see sharp pain accompanying that non-painful stimulus. Most commonly it's going to be along the maxillary branch of the trigeminal, so there's going to be 3 major branches here. We're going to get the ophthalmic hitting the top, kind of near the orbitals, so that's the op part of that, right? The maxillary portion is going to hit the upper jaw there, and then the mandibular portion is going to hit the kind of lower jaw, heading on up on the side there. You can see the cartoon. So 3 main branches, and compression on any of these is going to then cause pain in that distribution. Imaging can help us determine what might be the cause, whether it's a growth of a tumor or whether there's a vascular cause here. So here we can see the superior cerebellar artery there, is lighting up, so we can see some inflammation. This is going to suggest to us that we have some sort of damage along the superior cerebellar artery there, and this is an artery that's going to run very close to the trigeminal nerve. And so when you go in and actually take a look, you'll see the sagging of that vessel, and it's actually compressing the trigeminal nerve there, and that is our problem. So the mechanism is really going to be compression, and for the most part that compression is going to be caused by blood vessels. It could be because of sagging due to age. There can also be abnormal development of blood vessels that has them run a little too close together, and they can actually pinch the trigeminal nerve. So it can get pinched between arteries and veins in some cases, but that age-dependent weakening of blood vessels causes them to sag down on the nerve. When we sag down on the nerve and compress it, that can lead to demyelination. So the large myelinated fibers that carry non-painful sensation, whenever we have the sagging of an artery here putting pressure on it, that leads then to focal demyelination. And when we lose that myelin sheath, of course we're going to be exposing a large area of the axon that's going to need to have ion channels reinserted, and those much smaller fibers that are going to carry pain signals, so this will just be tactile up here, much larger and myelinated, with pressure demyelinated, so that when action potentials are being conducted back, so when we have non-painful stimulation, these tactile fibers are going to be stimulated, but during the action potential, when it passes through the axon, remember we're going to be spitting out potassium. Normally we have myelin here to insulate the axon, but with compression and loss of myelin, that buildup of extracellular potassium excites the pain fibers, and then we feel pain as a result. So it's a factor transmission all over again, same thing, just with a different nerve, and so we have different symptoms here. Now, the progression of this disease is variable. It kind of depends on whether we can identify a cause and whether we can easily treat that cause. Something like the sagging of that superior cerebellar artery there, we can fix that. So surgically, we can remove that compression by just simply pulling up the artery there so it's no longer sagging down. Once we relieve the pressure, remyelination can occur, so that as the action potential passes through, it's buffered, it's not sending out potassium here, we don't stimulate pain fibers, we don't feel pain anymore. If there's a tumor growth that can easily be removed and relieve compression, that's also going to have good prognosis. If we can't find a treatment, there's a small chance that this could remit spontaneously, but it could also just increase in frequency and intensity. So the prognosis is variable. If there's a known cause and it's treated, prognosis is excellent. Surgery is going to be used to relieve compression. There are also anticonvulsants that are used that really just decrease the excitability of nerve fibers. So these are going to be sodium channel inhibitors. That's going to prevent the initiation of action potentials, and it's going to make neurons a little less excitable. So what we do is just tone down the excitability of neurons so that it's much harder to then have that effective transmission occur. Post-polio syndrome, rather than being a sensory problem, here this is a motor issue that's going to occur. So this is only a risk for people who have had prior polio infection. So if you haven't had polio, you're not at risk for post-polio syndrome. But post-polio syndrome is going to be the reemergence of those symptoms after a few decades of latency. This is going to be pretty rare, of course, unless you have polio, but as far as the population is concerned, this is a pretty rare disorder. In polio survivors, it's going to be about 40%. Now, of course, since the development and widespread administration of polio vaccines starting around 1955 or so here in the U.S., we've essentially eradicated polio, and it's not much of a problem here. Of course, before then, you can see here we have a handful of children who they've had to put braces on to help straighten their legs out there. This is no longer really an issue today, but there are plenty of survivors of polio who are going to suffer from post-polio syndrome. The clinical presentation here is going to be weakness, and it's going to be progressive muscle weakness, resurfacing, and then persisting for at least a year. So after the initial period of poliomyelitis, there's kind of a latent period where the virus lays dormant. Then it reactivates and creates post-polio syndrome, killing off some of the remaining motor neurons. Because what polio is going to do is infect lower motor neurons. So if we have a few lower motor neurons here, they're going to innervate some muscle. Here we have cerebral fibers, and they're going to have their own targets. Poliovirus will infect and then move up the axon, and the motor neurons that it infects will die as the virus reproduces. This is of course going to lead to motor weakness and paralysis, but we get some recovery because those peripheral axons can regenerate. So when we have some denervation here, the remaining axons can head on over and hit those denervated neuromuscular junctions. Now, not every neuron is going to die off. The virus is going to stay dormant in some motor neurons, and when it reactivates years later, then these die off, giving us a fresh wave of motor weakness. So I'm going to let the video play here. We're going to see a lady with post-polio syndrome here. You can see, obviously, she needs assistive devices to move around because of the weakness. And here she's going to make her way up the stairs. So we're going to see a lower motor neuron type weakness here. We're going to see the wasting of muscles because of that loss of motor neuron innervation. And you can see she's making it up the stairs. It just takes a very, very long time and is quite difficult. The disease mechanism here is going to be just after an initial infection with poliovirus. That virus is going to enter motor neurons, kill them off as shown here. It's going to be a subset of those that are infected. So many of them will remain alive, and then that post-polio syndrome is going to arise if the virus reactivates, or just the wear and tear on the surviving motor neurons. So these motor neurons have to work about twice as hard as they did in this cartoon world because we lost half of our motor neurons. So they're going to be more active. A more active cell is of course going to create and use up more ATP, and the creation of that ATP is going to create free radicals. Same thing that we've seen in several different neuron populations. It's kind of like Parkinson's disease affecting dopamine neurons. In this case, it's a virus killing off motor neurons, and then the remaining survivors having to work a whole lot harder. With that additional ATP production and the additional production of free radicals, the proteins, DNA, and lipids within the cell have a higher risk of getting damaged by the free radicals as a result. If we accumulate enough damage, then the cell undergoes apoptosis. As far as treatment goes, physical therapy is going to be the primary treatment here. So we need to find a way of reducing muscle fatigue, and you all will know far more about that than I do. But here's a gentleman who's going to tell you his experience with getting physical therapy.
I am coming here for twice a week for about an hour, and mainly we are doing for strengthening the muscles and helping the blood circulation, you know. When I came here the other day, I was very happy if I could walk with a walking stick, and that it is supporting. You know, I still have it in the car, but you know now it is not the case. You know, so I can now walk more freely, And the only problem with walking I have that I have to start thinking about improving my posture.
So in some cases, it can be a virus that's targeting neurons. In some cases, viral infection can sort of mislead the immune system into targeting our nerves. So in this last part, we're going to hit some autoimmune disorders, and then we'll hit our heritable Charcot-Marie-Tooth disease at the end. So with Guillain-Barré syndrome, we're looking at transient autoimmune targeting of myelin proteins. And Guillain-Barré syndrome is going to come on after some sort of viral or bacterial infection that stimulates an immune response. In rare cases, it can be vaccines leading to this autoimmune targeting of myelin, but what we're going to see is the destruction of the myelin sheath. And when we destroy the myelin sheath, this can impair the conduction of motor and sensory signals. If it's prolonged, this can eventually lead to the destruction of axons as well. So the clinical presentation here, we're going to have both motor and sensory dysfunction. So in polio, it's really a motor disorder because it's a specific virus targeting a specific neuron population, and that would be lower motor neurons. In this case, we're targeting the myelin sheath, and of course both motor and sensory fibers are myelinated, and as a result, both functions are going to be impaired. So we're going to see some paresthesia. It can lead to then pain because we have impaired non-painful sensory function. Of course, we're going to see a lower motor neuron type weakness because we're affecting the myelin sheath of lower motor neurons. So we'll see reduced reflex amplitude. We're going to see limb weakness as a result, and only if this remains for a prolonged period of time are we then going to start to see any sort of muscle wasting. But for the most part, it's self-limiting and it's going to resolve spontaneously. We're going to hear someone else's story here about their time with Guillain-Barré syndrome.
Cooking breakfast is a simple task, but to Beth DeVries, it's much more.
I couldn't even hold the egg, let alone crack it.
You see, Beth survived 2 episodes of recurrent Guillain-Barré syndrome. Symptoms started in her feet.
It's like I couldn't feel the floor.
Numbness and weakness progressed quickly throughout her body.
But I walked into the kitchen and I fell on the floor, flat on my face, and I couldn't get up. I couldn't move.
So that's pretty profound weakness there, just falling spontaneously. So she had a couple rounds of Guillain-Barré syndrome, and that's because of a few different rounds of this autoimmune targeting. So for whatever reason, her immune system is producing antibodies against myelin proteins. When the immune system targets myelin, it recognizes it as being foreign and destroys it. Of course, if this is transient, then we'll just have demyelination followed by remyelination. Everything will be fine. If this is prolonged and where we have extended periods of time with demyelination, those large fibers are going to be producing more ATP than they would normally. That'll lead to metabolic stress, same thing that we've covered time and time again. For the most part, we're going to see spontaneous recovery in the majority of cases because Schwann cells can regenerate. So glia are not post-mitotic like neurons. They can go through the cell cycle and make more of themselves. As far as treatments go, what we need to do is prevent that autoimmune targeting of myelin proteins, and this can be accomplished through plasma exchange to try to get rid of the autoantibodies, or we can mask the autoantibodies or suppress the chronic inflammation that occurs by using intravenous immunoglobulins. So we put in a whole bunch of antibodies that kind of get in the way of these autoantibodies, either targeting myelin or mounting an immune response to myelin. Another autoimmune disorder here targets not the myelin, but instead the neuromuscular junction, and that's going to be myasthenia gravis. This is a little more common, so we're going to see it about 20 per 100,000 as opposed to just 1 with Guillain-Barré. More commonly affecting females than males, we're going to have about a 1 to 1.5 male to female ratio. You can see here over the years, women are the circles, The triangles would be the men, and the squares are the total population. So you can see in the sort of 20s to in the 50s, women are more commonly going to have myasthenia gravis than men. Only when you get in the very advanced age groups do you see men overtake women, but there's so few people in that age group. As a whole, we see more women affected than men. A very common risk factor here are going to be disorders of the thymus. So either hyperplasia or thymomas are going to then increase the risk of myasthenia gravis. And in the majority of cases of myasthenia gravis, you see some sort of abnormal growth in the thymus. The thymus is going to then produce antibodies that target the neuromuscular junction. The neuromuscular junction is, of course, the site where we communicate between motor neurons and muscles. Here's our postjunctional folds. Here's our muscle. Now, when we draw this, normally we just talk about acetylcholine receptors. Then over here, we'll just kind of shade them in a bit. And we talk about the motor neuron spitting out acetylcholine, and that's all it is. And it's just floating there freely. Of course, that's not true. The motor neuron is not sitting there floating freely. It's attached, and we'll talk about the attachment in just a moment. But what we see is autoimmune destruction of the neuromuscular junction. So we're going to see a reduction in the number of acetylcholine receptors. Whenever we have fewer acetylcholine receptors, we get less pronounced depolarization of the muscle. It's more difficult to excite it, and as a result we see weakness. So it's going to be sort of a lower motor neuron type weakness here. We're not properly stimulating the muscle. Now there's kind of two general patterns of weakness that we see. My mind is weak right now. One pattern only affects the eyes, and the other pattern can affect anywhere. So there is ocular myasthenia gravis, and then there are several types that can affect eyes, the rest of the body, kind of in a mixed pattern here. But that ocular weakness is fairly common, and we can see an example of it there. As far as diagnosing myasthenia gravis, what's going to undoubtedly rule in myasthenia gravis is the detection of those autoantibodies, the antibodies that target components of the neuromuscular junction, like acetylcholine receptors or a few other things that we'll get to in just a little bit. But detecting those autoantibodies, that's going to tell you myasthenia gravis for sure. We can measure the EMG, compound action potentials that occur when we stimulate the motor nerve, and with repeated stimulation, what we should see is a weakening of the muscle response. That is going to tell us myasthenia gravis. Of course, we want to see the clinical symptoms of weakness, especially with repetitive activity. So the muscles are highly fatigable as a result. Many patients are going to respond to cholinesterase inhibitors. So because we have fewer receptors here, if we inhibit cholinesterase and don't break down acetylcholine, then acetylcholine can build up and better activate those fewer receptors that are present at the neuromuscular junction. Not everyone's going to respond to that, and a response to it doesn't necessarily rule in myasthenia gravis. Those antibodies and the increased fatigability of the muscle are going to be the two key diagnostic tests that are going to rule in myasthenia gravis. Depending on the muscles that are affected, we're going to see weakness. So if it only affects the eyes, we'll see ocular weakness. That can lead to double vision because we have a hard time putting our eyes in the correct location so that what we're looking at is in the same spot for both eyes. And so you may see some head turning to accommodate the inability to properly line up the eyes, of course drooping of the eyelids. But this can affect anywhere. It can affect the limbs, most commonly proximal limb muscles. It can affect respiratory muscles, and that would be obviously a major complication. The way that this weakness comes about is through autoimmune destruction of the neuromuscular junction. So what we always leave out when we draw the neuromuscular junction is all the stuff that holds it together. Motor neurons have this protein called agrin that mark them as motor neurons. This is the protein that tells the muscle that a motor neuron has arrived. Agrin is going to interact with lipoprotein-related protein 4, so LRP4, for those of you keeping score at home. And this is a protein that's tethered to the muscle. LRP4 is going to then stimulate muscle-specific kinase, or MuSK. This is a kinase that's specific to muscles, as the name suggests. And what MuSK does is stimulate the clustering of acetylcholine receptors at the neuromuscular junction. So only when MuSK is on do we put acetylcholine receptors at the neuromuscular junction. MuSK is only turned on when LRP4 binds to agrin. So we have to have a motor neuron there if we're going to go through the trouble of putting in our acetylcholine receptors. Autoimmune targeting of any of these 4 players here will lead to the destruction of the neuromuscular junction, because they either disrupt the function of acetylcholine receptors by, let's say, binding to them and blocking the binding site, or they disrupt this signaling pathway that says that a motor neuron is there. So if we bind to LRP4, for example, so if we disrupt that interaction with agrin, LRP4 doesn't get activated, MuSK isn't activated, we don't put acetylcholine receptors there. It's exactly the same as if we lost the motor neuron, but we haven't. These antibodies just get in the way and prevent the motor neuron from conveying to the muscle that it's there. And without that, we don't keep acetylcholine receptors around. So we can futz with these proteins, agrin, LRP4, or MuSK. That's going to reduce the abundance of acetylcholine receptors. Or we can bind to acetylcholine receptors themselves. And that's going to interfere with their either binding of acetylcholine, or it can cause internalization of acetylcholine receptors. The progression of myasthenia gravis is going to be progressive, but it's going to fluctuate. Symptoms can fluctuate within the day. It can also fluctuate over a long period of time. So we'll see some remission and relapse, but the remission is almost always going to be temporary. So it's going to be fluctuating and very slowly progressive. As far as treatment goes, cholinesterase inhibitors work in most cases, not all cases. I believe those that have anti-MuSK antibodies don't respond to acetylcholinesterase inhibitors. But by inhibiting acetylcholinesterase, remember that that's going to catalyze this reaction. That's the breakdown of acetylcholine into an acetyl group and a choline group. Boy, that is horrific. Okay, that says choline. I can't live with that. And a choline. This can get taken back up, used in the mitochondria for metabolism, or we can make more acetylcholine with it. But cholinesterase is going to break down acetylcholine. When we inhibit that, we build up acetylcholine, and those few acetylcholine receptors are going to be stimulated so we can overcome that weakness. Now, of course, this is going to create some side effects. Hopefully you remember cholinergic crisis from organophosphates. So we can kind of stimulate a weak form of that. Cholinesterase inhibitors aren't going to be used chronically in this case, because we can cause parasympathetic output to increase. We'll get some gastrointestinal distress and alterations in blood pressure. So it's really only used during times when the symptoms are most disruptive. So we have kind of limited bursts of cholinesterase inhibition. Of course, if there's any problem with the thymus, treating that is effective in the majority of cases. And since most cases have issues with the thymus, this is a common treatment option. So, removing tumor growth will obviously help cut down on that overproduction of neuromuscular junction targeting autoantibodies. And in some cases where we're not responding to cholinesterase inhibitors, then we can use immunosuppressants. They could either be corticosteroids or non-steroidal. So this is going to be effective in almost all cases. So by suppressing immune function, we cut down on autoimmune targeting of the neuromuscular junction. Of course, there are going to be some side effects of this as well. But by preventing autoimmune targeting of components of the neuromuscular junction, we no longer remove acetylcholine receptors. They can build back up, and we have normal strength as a result. The last disorder to cover is Charcot-Marie-Tooth disease, CMT there. So a little more common than myasthenia gravis, so now it's about 40 per 100,000. You can see that's highly variable here, depending on where they take their data from. So here I've just put up a few different numbers taken from a systematic review here. And this is a heritable disease, so you should, in most cases, have a family history, because nearly all are going to be dominant in their inheritance pattern, either autosomal dominant or X-linked dominant. There are some recessive forms though, so the parents might not necessarily have CMT, but their children will have it. In most cases though, it's dominant, so you will see passing down from parent to child. As with really anything, another risk factor for CMT is going to be other neuropathies, because they can worsen the symptom. So in CMT, we're going to see destruction of kind of long nerve fibers. So we're first going to affect the legs, and then we're going to affect the arms. So it's going to be kind of glove and stocking. We're going to start with the stockings. And genetic studies are going to be useful for diagnosing CMT, but also the pattern of wasting and sensory loss can help as well. So primarily we're going to see muscle weakness and wasting. In some cases there can be sensory disruption as well, but for the most part we're targeting motor neurons in CMT. Because the longer axons are targeted, we're going to see foot deformities. So you'll see kind of a high arch deformity. The toes can curl up and form hammer toes. The wasting of more distal portions of the legs creates that kind of inverted champagne bottle look, where the feet and lower leg have wasted much more than the upper leg there. The gait is going to be that of a high steppage gait, because there's difficulties dorsiflexing the foot there. So the foot's going to kind of hang down, and that's going to lead to a high steppage gait that we can see here. You'll also notice the more pronounced wasting of the feet compared to the upper legs there. So you can see high steppage gait, and that's to account for the weakness of the dorsiflexors there. Now, some cases of CMT are going to have sensory loss. So there's really two major variants of CMT. There's CMT1 and CMT2. In CMT1, we see the loss of myelin. And because it's a demyelinating disease, we have both motor and sensory impairments, as well as slowed nerve conduction velocities. With CMT2, this is going to cause targeted destruction of motor axons, so we usually don't see any sensory impairments. Of course, there's a variety of CMT2 subtypes, so in some cases there can be sensory loss. But this is a lot more specific for motor function. This does not affect intelligence, memory, or lifespan. This is, of course, a peripheral nerve disorder there. So, two main types. CMT1, demyelination. CMT2, we have impaired axonal transport. So a mutation in a variety of different myelin proteins can cause demyelination. And that's what occurs in CMT1. So if we look at these images here on the top and bottom, we're looking at cross sections of the sciatic nerve, which is commonly affected in CMT because it's quite long. On top, this is a normal sciatic nerve, so all the kind of dark, the electron dense regions there that are very dark, that's just showing us the myelin sheath. We have a collection of myelinated axons and some very hard to see, very small non-myelinated axons kind of floating within a single Schwann cell there on top. On the bottom, we're seeing that onion ball enlargement. So through demyelination and remyelination, we keep pulling Schwann cells to the axon, and rather than having a single Schwann cell surrounding it, on the bottom we still have our myelin sheath, but we also see these additional Schwann cells showing up for the party. And so there's layer upon layer of Schwann cells, and this creates an onion ball enlargement that can be palpated there. So you get a kind of a bulging forming through the chronic demyelination and remyelination cycles that are occurring. In CMT2, it's not a dysfunction in myelin proteins, but instead in proteins that are involved with axonal transport. In some cases, it's kinesin, the motor protein that actually pulls stuff on down. In other cases, it's with adapter proteins that help tether the cargo onto kinesin. And so these data are showing us impaired mitochondrial transport along the axon. D and E are showing us the chymographs for normal axons. F and G are showing us for the chymographs for axons that have mutations of the CMT2 type, and there's a variety of these. Part H on top there is showing us the quantification of the data. So the number of moving molecules, that's how many mitochondria could they pick up moving during their imaging time. You'll notice WT, that's wild type, has far more moving molecules than all those different mutations. So when we impair mitochondrial transport, obviously we're going to then cause axonal degeneration. We're unable to move mitochondria there, we're not making as much ATP, we're unable to move new proteins down the axon. Of course, we don't produce proteins in the axon, everything has to be imported. So when we have impaired axonal transport, we invariably get the destruction of those axons. And that's what then leads to that muscle wasting as a result. This is going to be, in most cases, a slowly progressive disease. We're going to start off with the longest axons, more commonly starting in the legs, heading on up to the upper limbs, and then the wasting will move toward more proximal regions in some cases. Treatments are really going to be symptomatic here. So we're going to use some orthotic devices to help with those gait abnormalities. Here we can see that high steppage gait is getting corrected with braces. Of course, physical therapy is going to be very important in these cases to learn range of motion exercises. So here we can see walking on flat ground. These braces also help CMT patients make their way up and down stairs. This is primarily what we're going to do to treat CMT. There's not much we can do to treat those heritable mutations that have occurred. All right, I got a few questions for you to go over here. Anything that isn't clear, go ahead and fill out the questions box or send me an email and we'll go through these on our weekly Q&A. I'll see you later.